All right. Caroline is a full-time speech language pathologist at TriHealth Rehab Hospital, an inpatient rehab center in Cincinnati, Ohio. She completed both her bachelor's and master's degree at Ohio State University before returning to her hometown of Cincinnati over 2 years ago. She helps run the Brain Injury Committee and leads the Brain Injury Support Group at TriHealth. Caroline is passionate about patient-centered care, health literacy, and neuro-resource facilitation for the brain injury population. So thank you guys again for coming. This is the role of inpatient rehabilitation for brain injury survivors. And Caroline, you can go ahead and take it away.
Awesome. Thank you so much, Chanda. Thank you all again for being here. I'm super excited to be here. It's, definitely an honor to be invited by the Brain Injury Association to present today. So thank you everybody so much for hopping on to this call, and for those that are watching, on Facebook or watch the webinar, thank you so much. So yeah, like Chanda said, today we're going to be talking about the role of inpatient rehabilitation for brain injury survivors. So I know she gave a little bit of background about me, but I'm just going to give you a little bit of further details. Again, my name is Caroline. I am a speech language pathologist. I graduated from Ohio State University with my master's degree in 2022, but did my undergraduate degree there as well. So for all of you Buckeye fans, I hope you're tuning in on Monday. Go Bucks. This is very exciting. I'm a huge football fan, so big game coming up next week. But yeah, so I have been working at TriHealth Rehab Hospital, which is in Cincinnati, Ohio, for about 2.5 years. I love my job, and I am so lucky to be in this role. I have some of the best coworkers, some of the best managers, and the best patients around. I could not be more blessed to be in the role that I am in. And as Chanda said, I'm really passionate about health literacy. So something we really pride ourselves on is helping our patients understand their healthcare conditions so that they can better manage them. I'm also involved in palliative care and comfort care, as well as neuro-resource facilitation. So we're going to talk at the end about some of our patient education that we do at our hospital. And a lot of this has to do with getting resources out to our patients and families so that they can optimize their care. So we're going to really be talking about inpatient rehabilitation, what this is, why it's important, and really go through the entire process today. So inpatient rehabilitation is intensive rehabilitation for patients immediately following their acute hospitalization. So this is a specific rehab hospital. Every patient that comes here receives 3 hours of therapy every day, split between physical therapy, occupational therapy, and speech therapy. Now, we do have some patients that are not brain injury survivors. Obviously, today I'm going to be talking specifically about brain injury, but know that you can come to inpatient rehab, and sometimes you don't always get all three disciplines. So for example, we might have older lady that fractured her hip, and she just needs physical and occupational therapy, but doesn't have, cognitive or speech concerns and doesn't need speech therapy. However, for our brain injury survivors, they always receive speech therapy. So for our purposes, we're saying these patients are getting 3 hours of therapy every day, split between three disciplines. And so where this kind of lands these patients is that they're getting 900 minutes of therapy in a week, which I know sounds really crazy. That's a really big number, and it is. But if you think about it, it kind of checks out to about 180 minutes of therapy every day, definitely Monday through Friday, and then some sprinkled in on the weekends. And so there's this kind of rule, this 900-minute rule, where patients have to get these 900 minutes of therapy in a week. And every patient's week starts on a different day. So if I'm a patient coming to the rehab hospital and I'm admitted today on a Tuesday, my week runs from Tuesday through the following Tuesday. So in that span, I have to get 900 minutes of therapy. Our patients are here for, on average, about 2 weeks, around 15 days. It can be shorter than this. We've had patients come and go in as soon as like 5 days. We've also had patients stay for, a couple of months, but that's really rare. On average, our patients are staying about 15 days in this inpatient rehab setting. So we're really going to talk about how do you get to inpatient rehab as a patient? How do you wind up here, and what happens once you're actually here? So first, the patient has to have some sort of need for rehab. And again, today, of course, we are going to be talking about brain injury. So that's going to be my, constant example. So let's say this person has a brain injury, whether that is traumatic, meaning their head made contact with something in the environment, whether that is a fall, a car accident, a sports injury, or non-traumatic, maybe it's a brain bleed, an infection, or a tumor. This patient is going to go to the acute care hospital first. When we say acute care, we mean those big name hospitals that you see in your area where you go if you're really, really sick or need immediate medical attention. In the Cincinnati area, we have TriHealth, Bethesda North, Good Sam, University of Cincinnati, Christ, and Columbus, they have Riverside Methodist Hospital, Ohio State, Mount Carmel. Up in Cleveland, there is University Hospitals, Cleveland Clinic. We're really lucky in Ohio to have a lot of really awesome hospitals. And so when you have a brain injury, that's the first place you should go. Do not delay care. We want you to get to the acute hospital first. And once you're there, we need to get you medically stable. So usually when you have bleeding in your brain or some sort of a brain infection or tumor, there's a number of things that can go wrong. And so we need to get you medically stable first before you even come to rehab. Because again, coming back to that 900-minute rule, you have to be able to tolerate 3 hours of therapy every day. And that's really intensive, especially for people that are, sick or weak or have, a number of medical concerns. So first we have to get you medically stable. And then once we're medically stable, we cannot accept patients that are on a ventilator. So that is an exclusion criteria. You cannot be on the vent to come to our hospital. You can have a trach, you can have a feeding tube, you can, have IVs and things like that, but you need to be able to be off the ventilator. And if you're familiar with the Rancho Los Amigos scale, which I'm not going to get into depth with today, but if you're a clinician and you're, aware of that, we typically take patients that are a Rancho 4 or above. So these patients can be confused, they can be agitated, but they cannot be in a vegetative state or a coma. Those are patients that cannot tolerate 3 hours of therapy a day, and therefore they cannot come to an inpatient rehab hospital. So we get you medically stable. You're off the ventilator. We're no longer in a vegetative state or a coma. Now we've decided you are rehab appropriate, so we got to get the ball rolling. There's a person called a clinical liaison who goes into the acute care hospital. So again, your Cleveland Clinics, your Ohio States, your University of Cincinnati's, and talks with the patient and family to do an interview of sorts. Not like a job interview, but basically kind of look at their chart, talk to the patient and family, and see if this is a good fit for them. And if we deem that it is a good fit for them, then we really start the business side of things. As everybody knows, at the end of the day, healthcare is a business, right? So lots of paperwork has to happen, insurance has to be processed. Most patients, like 99% of patients that come here, their stay is covered by insurance. It is extremely, extremely rare that people pay out of pocket to come here. It runs about $2,000 a day to pay out of pocket to come to inpatient rehab. So that is not something that people typically do. But once your insurance is approved, boom, you're in the door. You're coming to inpatient rehab. What's next? We're going to talk about the process. So this is just kind of an outline for what I'm going to be discussing throughout the rest of the presentation. What does it look like once you get to inpatient rehab, and why is this so beneficial for our brain injury survivors? So first day is admission day. This is a picture from one of our clean and empty rooms. I took this. This is a room like right across the hall from the office that I'm in. So this is what it looks like. Obviously, not every hospital, looks like this, but this is what my hospital looks like. All the rooms look, pretty much identical. So you can see the clean bed. They got their call light there. The first day is all about getting acclimated and just getting settled in. So the nurse is going to greet you. They're going to, get your vitals. We're going to make sure, you're cleaned up. We have a wound care team that's going to come in and look at you. Maybe you had a surgery to relieve the pressure in your brain. And so you have, a scar on your head. We're going to document that, and we're going to clean your wound and make sure we're, set up for success. We're going to, again, do a lot of paperwork. You're going to sign some stuff. The admissions coordinator is going to come by. But there's no therapy on the first day that you get here. It's all about just getting settled. And I think that's really important because things pick up very quickly. We hit the ground running the next day. And so we give our patients one day to just settle in. Most patients come in kind of late afternoon, 2 to 5 o'clock is kind of that sweet spot. So they get in the door, we get settled, they get dinner, and then they're just kind of hanging out for the first day to prepare for evaluation day, which is where therapy really starts and we jump in. So evaluation day, this is where we hit the ground running, like I said, and all three disciplines get an opportunity to first lay eyes on this patient and see what is going on. And I always tell my patients, you know, my name's Caroline, I'm here with speech therapy. I'm here to see how I can help you while you're here. Because that's really what it's all about, is how can I help you? How can I provide, you know, skilled services to help you achieve your goals? We'll talk about goals and, you know, what we're actually doing in the therapies here in a second. But on that evaluation day, physical therapy and speech therapy, we each get 45 minutes with the patient. And then occupational therapy gets 90 minutes with the patient, with the ultimate goal of getting them up and doing a shower. So evaluation day is really where, again, we lay eyes on this patient and we're just kind of getting a baseline. We're seeing, you know, where are they at? Where are we expecting them to go? We're, as clinicians, kind of putting the pieces together and thinking in our head, you know, what is this going to look like? What goals do we have for this patient? You know, where can we realistically expect them to land? And again, we do not have crystal balls. I say this all the time. As much as I wish that on evaluation day, I could answer, you know, the family's question of, well, you know, is my husband going to go home, or, you know, is he ever going to go back to work? I can't answer those questions on evaluation day. And sometimes I can't even answer those questions on discharge day. But what I can do is give you information on how they're doing, you know, right here and right now, and what skills and services I can provide to help them continue to make progress. Then we jump into treatment. And this is where I'm going to spend a bulk of the time that I'm going to be talking today. And also because this is the bulk of the time that patients are spending here. Again, 900 minutes of therapy, 3 hours of therapy a day. This is the meat and potatoes of therapy, of the rehab hospital. So we're going to get into a little bit about what each discipline does, what value they have. I'm going to be showing some of the kind of gizmos and gadgets that we use, some of the stuff that we're lucky enough to have here at my hospital. Again, I can't speak to every other inpatient rehab in the state or, you know, nationwide, but, you know, I feel very lucky to work at a hospital where we have access to such incredible colleagues and clinicians, as well as equipment. So starting out with physical therapy. Physical therapy is really working on lower body strength, mobility, and balance. So with brain injury, oftentimes people kind of tend to swing in one of two directions. Either they tend to have decreased muscle tone, so maybe their muscles once had a lot of muscle tone, using a hair tie like as an example, right? It could be taut, but maybe after their brain injury, it's a little more floppy. They have too much muscle tone and they're more flaccid. So we're trying to strengthen those muscles and start to get them wiring and firing a little bit more. Or maybe it's the opposite. Maybe their muscle tone is really tight. It's pulled too taut and they're spastic. So we're trying to get that range of motion, get that strength back, so we can kind of balance that muscle tone and get the amount of strength back that the patient had prior to their injury or accident. And we do this in the way of mobility. So when we think PT, we're thinking movement. We're thinking bed mobility, right? Rolling in bed, you know, it's for a lot of us, we take that for granted. We just, you know, throw our feet over the edge of the bed and boom, we pop up and we're good to go. For a lot of our survivors, even just rolling in bed and getting out of bed can be really challenging. Once we're, you know, out of the bed or to the edge of the bed, we have to get up out of bed. So, you know, how much assistance do you need getting out of bed and getting to your wheelchair? From the wheelchair, then we got to get to the bathroom, you know, into the hallways with walking. There's so many different, you know, surfaces and destinations that we go, and that's just within, you know, the patient's room or within the therapy gym, right? As, you know, people, we go a lot of places. And so we are always really trying to focus on what is important to the patient. Where do they need to go? What do they need to be able to do? And oftentimes that starts with, you know, the confines of their room, but very quickly once we're moving and grooving, then we're going to the hallways, we're going to the gym, we're going, we have a hotel route that's connected to our hospital. Maybe we go across to the hotel and we, get coffee from the little breakfast stand. We're doing all different kinds of mobility to challenge these patients, also with a big focus on balance. So our brain injury survivors oftentimes tend to move quite well. This is not the case for everybody, but oftentimes, especially with traumatic injury, people physically tend to recover quite well. Um, More so than non-traumatic injury, and physical things start to come back before that cognitive piece. So when we talk about physical therapy with brain injury, oftentimes we're looking at balance, specifically dynamic balance. So our balance while we're moving. Maybe this patient used to, work in a kitchen and they need to be able to reach up and grab things out of the cabinet. So they're shifting their weight to grab things. Maybe they have children that they have to reach down and pick up. So we're practicing, balance while you're, balancing a toddler on your hip, right? We're thinking about how is this patient moving before their injury and how can we get them moving again? Like I've said, my colleagues are amazing. They're so creative, and I'm constantly amazed by how they challenge our survivors' balance, strength, and mobility in creative and new fashions to target what's important to these survivors. When we think about occupational therapy, we're specifically thinking about upper body. So to contrast that with lower body, OT is looking at arms and hands. So again, similar to PT, where the legs might either be flaccid, so too little muscle tone, or spastic, too much muscle tone. We are working on that in hands and arms as well. And we kind of target this through doing these different activities of daily living. So things like getting dressed, getting showered, self grooming, personal hygiene, making a meal, cleaning up after yourself. All these things that we do as people to be successful in our daily lives. So we have something called the ADL suite, Activity of Daily Living Suite. And it's a big room where we kind of, it's like a little all-in-one apartment. There's a bed, there's a washer and dryer, there's a closet, we have a full kitchen, there's a big bathroom with a tub. This is kind of our hot spot for practicing these activities of daily living. We can take patients down there and really work on being able to do all of these tasks that they have to do to be successful. Again, our survivors, again, not everybody, but a lot of our brain injury survivors tend to move quite well. So maybe their strength in their arms and hands is pretty good, but their coordination and their processing for how to go about doing their morning routine is impaired. Maybe they need cueing to help them think about, okay, first I brush my teeth, then I have to comb my hair, then I wash my face, then I put my clothes on. We're working on the steps to be able to do these things with the ultimate goal of people becoming more independent in their environment. And then lastly, obviously I'm biased, but speech therapy, my domain, which I spend a lot of time with our brain injury survivors. Speech therapy tends to be a big hallmark of the rehabilitation process for brain injury. And there's three big domains that we work on. The biggest one by far is cognition. So just our fancy word for thinking skills. So cognition tends to be one of the hallmark impairments for people with brain injury. Cognition across the spectrum, starting with really basic, just alertness and arousal, being able to stay awake to even do anything. Sometimes we do have these patients that are really, really sleepy. And so we work with the medical team on, finding the right combination of medications as well as daily routine to get them awake and on a good sleep-wake cycle. Once they're awake, then we have to work on attention, being able to sustain attention to a task for a prolonged period of time. I have a gentleman right now who has a really difficult time with attention. And so yesterday we were just bouncing a beach ball back and forth. And then after 15 seconds, we would try to remember what the month is. So, kind of focusing on that sustained attention while also bringing in a memory target. So memory is another huge thing. I'm going to show you guys here in a second excerpt or a page from our therapy log or our rehab journal that we do with our patients. So memory is huge. We are constantly challenging the patient's memory, both memory of, personally relevant things, long-term stuff like, what's your wife's name? What's your birthday? That kind of stuff. But also, it tends to be more the short-term memory. What did you do in physical therapy this morning? What did you have for dinner last night? So working on that recall. And then, some higher level cognitive pieces. So things like executive functioning and self-monitoring. This is a huge thing for brain injury survivors. A lot of times these individuals have a difficult time recognizing their performance on a task, how they did with that task, and what they could maybe do to improve. So, sometimes I have to be the bad cop. A lot of times I have to be the one to say, hey, Betty, you just dumped a whole thing of water on the ground, and, why might that be a problem? What could we do in the future? Do we really need to fill it to the very tippy top? Those types of things. That kind of self-monitoring and self-awareness is a really big piece of brain injury rehabilitation. We also work on communication. So survivors can have any number of communication impairments, things like dysarthria, which is a motor speech disorder, where some of those muscles, like in their face, their lips, and their tongue might be weak, and it can make their speech sound slurred or a little bit muffled. They can have what's called apraxia, which is a motor planning disorder, where they have difficulty sequencing the steps to do a motor task. Or they might have what's called aphasia, where they might have difficulty coming up with the words to say or understanding what someone is saying to them. So we work on all of these communication impairments. Not every brain injury survivor might have these, but these are something that we see all the time. The other piece of communication that I think people forget about that's a really big piece for brain injury rehab is social communication. Knowing what's appropriate and maybe what's not appropriate to say or do in conversation or in social scenarios. I think that this is also something that's really taken for granted amongst, kind of able-bodied people who are used to communicating in a social setting, knowing when to, let the other person have a turn to talk, or to, lower your volume if you're in a movie theater, or to talk loudly if you're in a restaurant. Sometimes our brain injury survivors have a hard time with these types of things. And so we have lots of conversations. Again, this is also when I get to be the bad cop and say, hey, was it really appropriate to ask that lady if she was pregnant and you don't know if she was pregnant? I have lots of conversations like that with my survivors. But these are really important things, right? Because we want them to go out into the community and be as equipped as possible to engage with all sorts of people in all sorts of environments. And so if we think it's appropriate to go up to random people on the street and ask if they're pregnant, well, that's a problem, right? So we have to kind of have some of those conversations. And then the last piece of speech therapy that I work on is swallowing. So dysphagia is the medical term for swallowing impairment. I work with patients all the time on whether it's oral dysphagia, so maybe they chew and chew and chew and chew and have trouble initiating a swallow, and the food is just kind of hanging out in their mouth. Maybe they can initiate a swallow, but things go down the wrong way and they're coughing a bunch, which could put them at a high risk for infection. There's exercises that we can do to help strengthen their swallow muscles. And we also have something here, a scope procedure that I do with patients if it's necessary to put a scope through their nose, feed it through, and see how their swallowing is looking, and make some decisions about what's safe or unsafe to consume. So this is a big bulk of what our patients are doing here. Again, they're spending at least 3 hours a day in therapy. So this is just kind of a brief overview of, what each discipline works on. I'm going to talk now about some of the equipment that we have and some of the different things that kind of set inpatient rehab apart from, like your outpatient or your home therapy, which are also super important. Nothing against outpatient or home health, because those are super important services. And most of our patients go on to receive those services after they leave here. But I think the reason why inpatient rehab is so important to get these brain injury survivors in the door is because this is the kind of stuff that you're not going to find, at your local clinic or, certainly people are not driving around in their cars. Your home health therapist cannot have these in their back seats. And so, for our survivors that have some more physical and cognitive impairments, we really want to get them in the door. And we know that neuroplasticity, our brain's ability to change, our brain's ability to grow new nerve cells and respond to interventions, is really at its peak in this first kind of 2 week to kind of month interval right after the injury. So again, once we get them medically stable, we want them to get sent to us right away so we can start using all this cool equipment. So on the far left is something called an exoskeleton. This is a wearable skeleton that can be fitted for patients and can help them move their limbs, well, their legs specifically. You can see in the photo, the gentleman has a cane with him as well. So you can use this with a walker, you can use it with a cane. And it has some really cool electrodes and kind of stimulation that can really get the leg through that swing phase if it's kind of dragging a little bit. This is really cool and can often sometimes jumpstart that mobility process for our survivors. In the middle is something called an AFO, an ankle foot orthotic. This is really nice and can be custom made for our individuals who might have a little bit of like ankle or foot instability. So if they're kind of wobbly on their foot, we can put this in and it can help them be a little more stable when they're up and moving. And then on the right is something called the Light Gate. This is a treadmill harness system. Again, kind of different than just your average treadmill that you might see at your local Planet Fitness, right? It has this kind of harness system, and it allows us to really challenge the balance of our survivors without having this fear of them falling. That's always something that we're looking out for with all of our patients, brain injury or not, but especially our brain injury survivors, because they already just hit their head. The last thing we need is a second brain injury. So this is a really cool piece of technology, and it can be programmed in a lot of different ways to challenge the balance, the walking speed, the incline for our survivors. Here I have a couple pictures of some things that patients might do in occupational therapy. So in the top left is something called the BITS. You can see the 3 different screens there. It stands for Bioness Integrated Therapy System. We just call it the BITS. It's just kind of it's a brand, but it's a type of equipment. And we have the one that's in the middle, the big TV screen. It's an app, or a number of apps are installed on this program. There's things working on vision, processing speed, kind of working on that hand-eye coordination if you're tapping things on the screen. There's a bunch of really cool stuff that you can do on here. And we can also be working on that balance too, because if the patient is standing and the TV is elevated to be kind of in line with their eyes, we're working on, reaching and standing as well. So lots of really cool things that you can do on there. On the top right, I have a bedside commode. So I talked about adaptive equipment earlier a little bit, but I think one thing that our OTs do an excellent job of is really figuring out what special stuff can we get to help this patient be successful. And we're so lucky that we live in an age where technology is booming, and there's always something new that's coming out to help patients be successful with their activities of daily living. So a bedside commode is just one example of that. Obviously, you can put this right next to their bed. So in the middle of the night, if they have to use the restroom, they don't have to get up and walk in the dark into the actual bathroom. Maybe they just have their little bedside commode right there. Also, a lot of these bedside commodes can go directly over the toilet. So maybe during the day when they're up and moving and their, care partner is there with them, they can put this over top of the toilet. So maybe it helps them get a little bit of a boost up or raise so they don't have to get all the way down to the low height of the toilet. There's also things like sock aids, shoe horns, reachers, toilet tongs, the list goes on. There's a million pieces of adaptive equipment that can all be really helpful in helping the patient increase their independence with their activities of daily living. Again, our clinicians are really good at kind of finding what works for the patient and helping them use that effectively. And then at the bottom, this is something called the Armio spring. This is a kind of piece of equipment to help with hand and arm strength and coordination. So there's different kind of games and activities you can do to help strengthen that arm and hand. And it provides what's called biofeedback. So the patient is getting information about how well they're doing on the task so they can see in real time, am I doing as good as I thought I am? Is my hand hitting these targets, or, do I need to be trying a different tactic? But we are really lucky to have all of these things available, and most inpatient rehabs have a lot of these technologies. And then lastly, speech therapy. Again, these are, this is kind of my area of expertise. So on the left, you'll see a pillbox organizer. So I mentioned at the beginning that I'm really passionate about health literacy, helping patients understand what's going on with them and helping them be successful in their own environment. And a huge part of that is medication management. So we spend a lot of time with our patients, if they're appropriate, of course, if this is, if we have mastered some of the lower level cognitive skills and now we're working more on memory and insight and problem solving, on medication management. So knowing what you're taking, why you're taking it, how to remember to take your medicine, what to do if you forget to take a dose, how to sort your pills into the organizer. We spend a lot of time doing this, and we as our own hospital have developed kind of a standardized medication management protocol. If anybody's a clinician that's listening and you're interested in that, definitely let me know. I'm happy to provide some more kind of assistance with that and let you know what we're doing at our hospital, and also very open to dialogues with other hospitals too about what you guys are doing, because we're always looking to learn and grow and expand what we're doing with our patients. In the middle there is a screenshot of an iPad with the F-Stack, the Functional Standardized Touchscreen Assessment of Cognition. The F-Stack is a really, really cool app for my higher level cognitive patients working on some of these daily tasks that they are going to be expected to do, in some capacity at home. So there's a grocery shopping task where they have to go throughout the store and they have a list of items they have to retrieve. So working on memory, working on executive functioning to see, are they running all over the store, or are they, making some sort of a pattern so they're not up and down every aisle. There's a bill payment task on there, practicing calling, to pay a bill using a credit card. There's different money tasks. There's medications on there as well. I love this app. This is really, really cool. We're super lucky to have this. And I use this a lot with my higher level people. And then the last thing that I have on there is a screenshot of a page from our rehab journal. Every patient receives a rehab journal when they get here, and this is a hallmark of their speech therapy intervention. Within the rehab journal, there's a bunch of different activities, everything from talking about goal setting, for each discipline, helping them remember, who their therapists are and what their names are. And then a lot of the pages, all the pages in the back, are this therapy log. This is where the patient has an opportunity to write down and track what they're doing in their sessions, who they're with, why they're doing it. Again, we're working on memory with a lot of these people. So we want them to know, when was your therapy? Who was it with? Where were you? And what were you doing? So each day they go through and, with assistance from us, and eventually hoping to progress to independent, writing down their schedule in that first time column. So, 9:15 OT with Abby, 10 o'clock speech with Caroline, and then go throughout the day. And then in the second column, writing down a couple bullet points about what they're working on in each of the sessions. And so this is a really nice way for us to kind of look at their episodic memory. So how much are they remembering the details of their sessions? But then I also assign my patients homework and I say, okay, you have 2 more therapies later this afternoon. By the time I come in tomorrow, the rest of this should be filled out. So we're looking to see, can they carry over what I have taught them, this idea of remembering to remember, this perspective memory. And this has been a really great tool that one of my colleagues, Mark, has created and that we have all adopted. So on the whole, between PT, OT, and speech, our brain injury survivors are doing a lot of different things. We are constantly challenging them from a mobility standpoint, from a self-care standpoint, from a cognitive standpoint, and hoping to progress them to as independent as they can be as they prepare for discharge. Speaking of discharge, Next part in the process is a care partner meeting. So a care partner meeting is a meeting that happens for all patients, generally between days 4 through 6 of their stay. After they've had a couple days, we've kind of gotten to know them a little bit. We kind of, got their vibe, see how they're going or how they're doing. We have a meeting with the patient, the family member, whether that is, one person, maybe it's just the spouse, or maybe it's, all of the kids. It can be any number of people. The case manager, so the social worker who's managing their case, and then the therapist. So we all get together at a specified time and basically answer these 3 questions. First and foremost, how are you as the patient doing? So the therapist is going to report on how this patient is doing across the 3 disciplines. So only one therapist attends. So if I have Betty Joe's care partner meeting and I'm the therapist on the case, if Abby's the OT and Sarah's the PT, they're both going to send me messages about how Betty Joe is doing in OT and PT, and I'm going to report for the family on how she's doing. So, how is this patient doing in therapy? Patient is making excellent progress. She's super motivated. She walked 100 feet. Or maybe this is a hard conversation. This is the first time where we really start to sit down and say, hey, maybe this isn't going as well as we thought it would. And this does happen. As much as I am, so pro rehab, and I think, a lot of patients are appropriate to come to this setting. Sometimes that's not the case. And that's okay too. And that's why we have these meetings to discuss, how are you doing? Are we making progress? Are we moving in the right direction? Or are we not seeing the improvements that we were expecting to see? And if not, let's start putting our heads together and come up with a plan. And if you are making progress, we're still going to put our heads together and come up with a plan. So then we're going to try to answer that second question. Where are you going? 80% of our patients discharge to home across the board. At least like roughly 80 to 85% of our patients go home, which is amazing. About 10% of them get sent back to the acute care hospital. So let's say Betty Joe is not doing well in therapy. She's been really lethargic. She's been more confused. We're noticing that something's not right with her. Maybe she needs to go back to, Ohio State Hospital, and we need to get something checked out. Maybe there's something else medically going on. Or the other 10% go to a skilled nursing facility. So maybe at home, for whatever reason, this patient is not able to go home. Maybe Betty Joe needs maximum assistance for mobility, and her husband, who is 85, is not able to provide that level of support. Maybe her husband is able to provide the support, but the kids live out of town, and the husband is not able to transport her. Maybe he can provide physical assistance, but she can't get to her appointments. Maybe they cannot afford the things that the patient needs to go home. There are a number of factors and variables that play into, where is the patient discharging? But on the whole, our patients tend to go home, which is awesome. And home is always the goal. So in this meeting, we talk about where is the patient going and how much assistance are you going to need when you get there? Physically, cognitively, self-care wise. Maybe you're good to go to get your pants and your shirt on, but you need help putting on your socks and shoes. Maybe you're okay to be walking in your home, but you need help with remembering to take your medicine. So we have this whole meeting to talk about what is the plan. We're getting our ducks in a row as it relates to the patient's discharge and figuring out how are we doing, where are we going, and how much help are you going to need. Then, as we approach discharge, we do something called family training. So family training is a set aside time for our families and care partners to get practice with the patient. So again, 80% roughly of our patients go home, and generally they need some level of support that they did not need before this injury. Okay, so maybe, husband was completely independent with his medications, and now he is more confused. And so his wife needs to learn about his medicines and how and when to take them. Maybe he needs a hand on him while he is going to the bathroom. And so we allow his wife to come in to practice taking him to the bathroom. Families are always welcome. We do informal family training all the time, and we love to have care partners at our hospital. But family training is a set aside time to go over some recommendations for home and give these families an opportunity to have kind of a question and answer type situation, as well as hands-on practice, so that they feel comfortable with the patient's level of care. We want to make sure that these families are as equipped as possible for this discharge. Our case managers have this kind of saying, they always say, we don't want a shotgun discharge. We're not doing a shotgun wedding. We're not doing a shotgun discharge. We're not just sending these people home with no planning, no preparation. We got to make sure that we have everything on board so that these families feel prepared. So we get PT, OT, and speech in there. Let's say this patient has a feeding tube. We get nursing in there to teach them how to use the feeding tube. Maybe they have a wound. We get our wound care team in there. So it's all hands on deck for family training. And I think that this is really a pivotal moment because it's showing, okay, this patient is close to discharge. We're kind of tying everything. We're putting a bow on it. We're making sure that these families feel prepared and ready for this discharge. And then it's discharge day. Woo! That is, what patients are always excited about, and we're excited for them because our patients make great progress and we're so proud of them. So we are super excited when our patients get out of here. But of course, a couple things have to happen before that. In terms of how do patients get home, most patients go home with their families. So we have a car simulator here. And so we practice car transfers prior to the patient discharging. So if, they have a little sedan, we make sure they can, scoot their bottom into the sedan. If they have a massive, Ford truck, we can crank our simulator up so they can practice that big, step up into the car. If for some reason the patient cannot go home with their family member, maybe their family member doesn't drive, maybe they need more assistance getting into the home, whatever the situation is, we do set up transport for our patients all the time. So you can see in that picture that just like a normal kind of transport van, it's not like an ambulance or anything, but just a little transport vehicle. And then those individuals can get the patients into their home. We make sure that they have all of their equipment. So durable medical equipment, or DME, that is taken care of ahead of time. Some of it is mailed straight to the patient's home. So if they're getting like a hospital bed or a big wheelchair, we just drop it off on their front porch. But little things like walkers or, shoe horns, that kind of stuff is just sent right to their room, and they take it with them on the day of discharge. And then, of course, we make sure all their medications are set up. So the doctor comes in the day of discharge, the nurse goes over all the medications with the patient, but the doctor sends the script to whatever pharmacy the patient prefers. So if they're like, yeah, I have a Walgreens right down the street from me, we just send that right over to their Walgreens and they pick it up on their way home. So that's the process. That is brain injury rehab in a nutshell as it relates to inpatient rehabilitation. I could sit here and talk for another hour about some of the other awesome things that we do, but I want to wrap up by talking about specifically for brain injury, what are a couple of other things that we do and have in place here in the inpatient rehab setting that, again, you're not getting at home, you're not getting it outpatient. What are we doing to help support our brain injury survivors? The first thing is something called behavior rounds. Behavior rounds is a time where we as a team get together. So myself, physical therapy, doctor, pharmacy, nurse manager, therapy aide, we all come together and talk about any patients that are having behavioral concerns. And that could mean a whole slew of things. That could mean, the patient is not sleeping well at night and they're, up all night and then they're asleep during the day, so they're missing therapy. Maybe it's they get really agitated during the day or specifically in the afternoons. Maybe they start to sundown and they get more confused. Maybe they have a certain trigger. Maybe they really hate when the kitchen brings them mashed potatoes and they lose their mind. There is a whole number of things that could cause patients to have behavior concerns. So we have this meeting every Thursday, once a week, and really talk about, what is the plan? How can we identify these person's triggers and how can we help manage them? So patients with brain injury, as we know, a hallmark concern of brain injury is behavioral or social kind of personality changes. So maybe this, patient used to be super calm, super chill, and all of a sudden, they're agitated, they're more upset, they're irritable. We're working to find, both from a medication standpoint as well as, non-pharmacologically, what can we be doing to help these patients be successful in this setting? So we come up with behavior care plans if necessary, which is kind of a list of recommendations and triggers, anything that the team needs to be aware of, and we put that in their chart so that everybody can see it. So whether you're the new night shift aide and you've never met this person, or you know them really well, you have access to knowing what is going to help this patient be as successful as possible. We have something called the safety coach room. The safety coach room is a room available for all patients, not just brain injury, but our brain injury survivors often attend this room. It is staffed by either our nursing aides or our recreational therapist. And this is a room where they can go kind of to have increased supervision if they're more impulsive, also to give them something to do. So maybe, if they're into art, we might do, a coloring project or watercolor. We have had some young, really young people. We have like the Wii Sports, or playing, Mario Kart on the TV. This might be a room where they just need a change of scenery. Maybe they just need to be out of their room and just want to listen to some calming music. That's cool too. But this is really nice for our brain injury survivors who tend to be a little more restless, maybe more impulsive. We want to make sure that they have a safe environment and that they're not just in their rooms all the time because we know that that can, cause them to be more agitated, potentially get up and have a fall, which we want to avoid. And then lastly, something that is kind of my baby, something that I created and something I'm super passionate about is our brain injury family education sessions. So as we know, brain injury is really challenging. Nobody ever signs up for this. Nobody ever thinks I'm going to be in the hospital, with a brain injury, whether, the patient or the family. And it really flips people's worlds upside down. And so our job as clinicians is to give these patients and families as much information as possible to really equip them with all the tools in their toolbox so that they can be successful moving forward. So after that care partner meeting that I mentioned a little bit ago, I spend another additional 45 minutes with every brain injury family and patient and give them a whole big stack of resources and go over information with them regarding their stay here and kind of what to expect moving forward. I tell all my families, the brain is really complex. There's no way for me to go over all of this in 45 minutes, but here's some things that can get you started. I don't want to overwhelm you, but I also want to give you the information that you need to be a good care partner or to understand your accident or your injury. So we kind of do that at the beginning. I have, again, a whole big folder of information, booklets, resources, etc. And then we do it again at the end. We kind of say, hey, all right, you've had a week or so to digest this, to go back. How are you feeling? Your husband's discharging in 2 days. Where's your head at? How can we support you right now? And I think that this is a really nice way to touch base with our families and make sure, again, that they feel as prepared as possible for this discharge. And then we have a support group here. We invite them to our support group. We get them set up with all the services in the area that they are eligible for, and really just make sure that they have that knowledge available to them. All right, I know I have been jabbering on for now 47 minutes, according to my stopwatch. And that was my goal, was to stop right around 47 minutes. So we have some time for questions. Thank you again all for listening. I know that was a lot of information, but hopefully that gives you a taste of what inpatient rehab really looks like for brain injury survivors, how you get here, what happens once you're here, after discharge, and why that this is such an important setting in the rehabilitation and recovery process for these survivors. But if anybody has any questions, either you can throw them in the chat or just unmute. I'm happy to answer anything.
Hello.
Hey there.
It was very informative. Appreciate it.
You're welcome. Thanks for hopping on.
Sorry I was a few minutes late.
No worries.
Is there a form you guys like to have filled out when somebody gets transferred over to you? Describing like our offices, they're going to be a lot more mild case, right?
Okay.
But maybe you'd like to know the date of the injury, the circumstances, the diagnosis codes, what we've noticed in the activities of daily living, things like that. Is there any specific paperwork that, as I said, I did come into the call about 15 minutes late?
Yeah, no worries. That's a good question. Do you mind if I ask, where do you work?
Yes, Columbus Injury and Rehab Center.
Oh, okay, very cool. Yeah, so I probably mentioned this like probably right before you logged on. So there's a person called a clinical liaison that is the facilitator of that admissions process. And so that's the person that you'll want to work with because there is a whole slew of information and we get something, they write up something called a pre-admission screen. We call it the PAS, PAS. And so this pass has everything you're talking about. So the nature of the injury, and even if it's mild, right? Like we have patients all the time. I think when people hear brain injury, they're thinking like, oh my gosh, like, you know, you had a gunshot wound to the head or, you know, this massive bleed. And we do see these, but more often we just see people, you know, maybe they were rear-ended and, you know, they just have a concussion and a concussion is still a brain injury, right? We see that all the time.
We have 3 offices in town, and that's what we see a lot of.
Yeah.
Patients that have some concussion symptoms, and you know, we're looking to co-treat and pass those along to help the person out.
Yeah, absolutely. So the clinical liaison, so I would reach out if you're in Columbus. So the inpatient rehab's there, Ohio Health Rehab Hospital, which is in Victorian Village. And then there's also the Dublin Rehab Hospital, which they're both owned by Select Medical, who also owns my hospital. And then I think there's one other one. I haven't been in Columbus for a couple of years now, as much as I miss it. But I would reach out to their people there because they have clinical liaisons. And what their job is to literally be that point of contact and they facilitate all of the paperwork. So they write that pre-admission screen, they get all the insurance things set up, they do everything to help with that process. That's a good question.
Great. Will those contact points be listed on that Facebook page or?
That's a good question, Chanda. I mean, I can find out who they are. I have some friends that still work there. I don't know, Chanda, if you know off the top of your head, like, and they change all the time too. But that is a good question.
I don't know off the top of my head, but if you want to send me an email, I can kind of look too for you and see if we can figure it out together.
Sounds great.
Thank you. I see somebody
Thank
raise
you.
their hand. Oh, sorry.
Yes, can you hear me?
I can hear you barely. If you talk a little louder, I think it might be a little better.
I'd like to know if you could email me a description of this webinar training.
Like email the PowerPoint.
Yeah, a description of the details, a description of the work of the training.
I'm having a hard time. I heard a detailed, Chanda, did you hear very well?
I think so. Michael, I can pass along the description that Caroline sent me that tells kind of what is in this PowerPoint. And if she's comfortable with me sending out the PowerPoint slides to everyone, I can also do that.
Yeah, that's totally fine.
Okay. I just need a description for my biography.
Oh, yeah. I can send you a certificate of completion too, Michael. Will that work with a description?
Yeah.
Okay, perfect. I'll do that for you.
Thanks, Chanda. Any other questions or any thoughts as we wrap up here? Okay, well, if you think of anything, I should have put my contact information on here, which I realized. But if you want to email, Chanda, if you emailed the presentation, if you want to put my email in there with it, that'd be totally fine. But yeah, if anybody has any other questions or you think of anything, or if you're just like, you know, if you're a clinician, if you have a patient and you're like, hey, you know, I'd love to pick your brain about whatever, I'm a certified brain injury specialist. I love brain injury. This is my, you know, area, my big kind of passion area. So definitely feel free to reach out. Again, thank you all so much for tuning in today. I super appreciate it. And I hope you all have a great rest of your week and go Bucks next week.
Thank you, Caroline. Have a good day, guys.
you.
Thanks. Take care.